Okay. Thank you all very much for joining. Welcome to our fourth webinar, I believe, and second of 2021. My name is Connor Handy. You may recognize me from some of the previous webinars, and I will be facilitating this evening's presentation by Dr. Shankle, as well as the Q&A session that we'll have after the lecture. Just a few housekeeping items before we get started here. Our session will start with a presentation from Dr. Shankle, as you all know, and then we'll open things up to Q&A. Some of you have submitted questions already. Thank you for those who have. If you have questions that you'd like Dr. Shankle to address, or anything comes up mid-presentation, please use the Q&A function. You should have a button at the bottom of your screen that you can click on and type a question that will come to me. And then I will bring those up when we have time in the Q&A session following the lecture. I may not get to all of them, but we'll try to get to as many as we can. And I'll relay those along to Dr. Shankle. Lastly, we are going to post a recording of tonight's webinar on YouTube and on the Shankle Clinic website in the coming weeks. So stay tuned for that. And if you know anyone that wanted to attend tonight but couldn't make it, that's where they can find the recording. I think that's it for administrative items. So most of you know tonight's speaker personally, but for those of you who don't, I'll give a brief summary of his qualifications. Dr. William Shankle is one of the country's leading experts in Alzheimer's and other age-related neurodegenerative conditions. He spent over 3 decades treating patients, fighting these diseases, conducting research to advance our knowledge of the brain, and developing new treatments to delay or prevent the progression of cognitive impairment. In 1997, Dr. Shankle founded the Shankle Clinic, a neurology practice headquartered in Newport Beach, California, focused on the management and treatment of neurodegenerative conditions. Prior to founding the Shankle Clinic, Dr. Shankle served as the clinical director for the Alzheimer's Research Center at UC Irvine, which he co-founded. He also served as the director of Memory and Cognitive Disorders Program at Hoag Neurosciences Institute. Currently, in addition to leading the Shankle Clinic, Dr. Shankle serves as the Chief Medical Officer for EMBIC Corporation, and he's the medical director for the Orange County Vital Brain Aging Program. Tonight, Dr. Shankle's lecture is titled Rethinking Alzheimer's, Prevent, Delay, and Reverse. So without further ado, I will go ahead and turn things over to Dr. Shankle. Okay, Doc, you should now be the host, and you can go ahead and share your video. There you are. Perfect.
Thank you for attending tonight. I wanted to talk about the concept of rethinking Alzheimer's disease. And this is the best way to put this would be to ask the question, how do we prevent most conditions that we can prevent? Well, we usually get a screening test, and we do it periodically. And literally every organ that we have has a disease which can be prevented by screening. For example, you have disordered breast cancer, ovarian cancer, colon cancer, the heart, the lung, blood vessels, kidney, liver. All the organs have preventable conditions, and we routinely get a blood test or some other screening test to detect it while people are still normal, and then initiate treatment to prevent the development of symptoms of those diseases. Now, we do screening for every organ we have except the brain. That's the one we don't screen for. And I think it's partly because there's a misunderstanding about what actually causes Alzheimer's and a misunderstanding that it is not treatable. It is, in fact, treatable. I see it literally every day. Now, we know, for example, that the majority of degenerative conditions of the brain are due largely to the abnormal folding of proteins that regulate cell function. When they are abnormally folded, as you can see on the right-hand side of this slide, they form aggregates. And these aggregates are highly, highly deleterious to nerve cells as well as other cells of the body. These misfolded proteins are different for different diseases. On the left-hand side of the screen, you can see the three most common misfolded proteins that cause degenerative diseases of the brain. The tau proteins that are misfolded produce frontal temporal lobe disease, including ALS, primary progressive aphasia, Pick's disease. The beta amyloid misfolded protein, you can see on the right-hand side of this slide that there are at least 6 different types of misfolding of amyloid alone. These produce Alzheimer's disease, cerebral amyloid angiopathy, and a variant of Alzheimer's called posterior cortical atrophy. Another misfolded protein called alpha-synuclein produces Parkinson's disease, Lewy body disease, and several others. It is important to know whether we have these misfolded proteins in elevated amounts in our brain. And why? Because we do have treatments that can block their accumulation and remove them. So let's see how these misfolded proteins actually can damage nerve cells, and at least one way we can get rid of them to keep an individual from getting worse. This picture shows, I'm just going to move, anyway. This picture shows that a picture is an example of a misfolded protein that, and they are in purple, these little purple squiggly things that are attached to this amyloid core. They form the aggregated misfolded protein. It then attaches to the cell membrane down at the bottom of the slide, and it literally punches a hole into the cell membrane. And when that happens, there's leakage from the inside to the outside, or from the outside to the inside of the cell. And since nerve cells, their function is to generate an electrical signal, there has to be a plus and a minus side on either side of these membranes. So when you keep punching holes into a nerve cell membrane, it can no longer generate an electrical signal, and it stops working. And if a nerve cell stops working, stops generating electrical signal, it ultimately will die. This is the basis for literally all degenerative brain diseases. Now, we know that the cell, all cells, by the way, they have many protective mechanisms against misfolded proteins because they are so dangerous. We have ways of unfolding a misfolded protein when it's detected. And if a misfolded protein gets past that defense, we have three different systems in our cells to get rid of the misfolded proteins. One of those are antibodies. We develop antibodies against the misfolded proteins, and they bind them, as you see on the right-hand side of this slide. The antibodies appear in red, and they attach to the purple misfolded proteins. And when they attach to them, they prevent them from binding to the nerve cell membrane. And there's literally a chaperone, literally a molecule called the chaperone protein, and it escorts these misfolded proteins bound by the antibodies outside of the cell, and eventually gets it out of the brain and excreted in the kidney. So this is not just a scientific concept. This is something that I have seen work for almost 20 years, starting by using it intravenously, which is still today the standard method. And then about 5 or 6 years ago, I was looking for a way to make it much cheaper, because when you inject it intravenously, it's about $5,000 to $10,000 a month. And all of you have, or not all of you, but many of you have heard of the new treatment approved by the FDA, Aduhelm, which is only approved for intravenous use. And its cost is about $5,000 a month. And there's a reason for that. The reason is that the antibodies have to cross from the blood vessel into the brain. And we know that only 0.1% of those Aduhelm antibodies, or any other antibody for that matter, cross from the blood vessel into the brain. So you have to give very large amounts to get it in. What I learned about 6 years ago was from an animal study that showed that a mouse inhaling these antibodies through their little nostrils, they get into the brain really well, about 30 times better. And what that means practically is that it lowers the cost from about $5,000 to $10,000 a month to $200 to $400 a month. As a result, I now have a cadre of over 110 patients with any of 8 or 9 degenerative brain diseases that have been treated by inhaling commercially available antibodies that bind to these misfolded proteins and remove them. And in every one of these disorders, with the exception of 2, where I do not have enough patients to know for sure, I have seen improvement on objective measures of function, cognition, brain imaging, brain volumes, and literally removal of the misfolded proteins from the brain. So this is a real phenomenon, and the majority of patients who have been treated with the intranasal antibodies have benefited. The one disadvantage of the commercially available antibodies is that only a small percentage of them actually target the misfolded proteins in the brain. In contrast, the companies like Biogen and others that are making pure antibodies against these misfolded proteins, 100% of the antibodies are targeting them. But the disadvantage is that they only target one of the misfolded proteins, so that if you have, let's say, if you have Alzheimer's and you have both the amyloid and the tangles, you need antibodies that remove both of them, not just the amyloid. And that's a disadvantage of the current FDA-approved treatments. So let me move on and talk a little bit about the importance of measuring these misfolded proteins in the cerebral spinal fluid. And this shows a summary of about 800 patients who have had spinal fluid testing. And we then measure the amounts of these misfolded proteins, which are shown on the X and Y axes. Based on that, there are well-established diagnostic criteria to definitively diagnose Alzheimer's disease and one other form of misfolded protein disorder called a tauopathy. And based on doing the spinal fluid in these patients, we've learned quite a bit. For example, about 10% of the individuals have no abnormal misfolded proteins, so they have something completely different. About a quarter of all the patients we've done spinal fluid on, they don't yet have Alzheimer's. They only have amyloid elevated. Now, in that case, a medication like Aduhelm would be really, really beneficial because there are no other misfolded proteins to remove, and the potential for prevention is real. Again, you would have to detect those people while they are still functioning normally to prevent the progression to symptoms. But one thing that most people don't realize is that only about 6% of these patients had only Alzheimer's disease. The majority of people have Alzheimer's plus the elevation of an additional misfolded protein called tau. So the majority of the time, what we're really treating is not just Alzheimer's, but Alzheimer's plus all the things that cause the increase in tau misfolded proteins, which are also called tangles. And believe it or not, the majority of the causes of that are poorly controlled medical conditions, lack of physical exercise, lack of cognitive exercise, depression, poor sleep, surgeries with anesthesia. All of these things can increase the production of the tau misfolded proteins. So by doing the spinal fluid, we now know which misfolded proteins are elevated, if any are. And that's important because the treatments we select depend upon which misfolded proteins are elevated. So for example, for the amyloid misfolded protein, curcumin elite is an extremely effective way to reduce them. I have used curcumin elite or similar forms for about 10 years. And typically I will see a 25 to 100% reduction in amyloid with a simple spice that's over the counter. For example, when the tangles are present, fish oil that's predominantly DHA type, not just general fish oil, but a specific type, DHA. They've shown in several studies that 2 grams a day lowers the tangle load or the production of the tangles by 10 to 15%. So also with Parkinson's, Lewy body disease, other disorders of a different misfolded protein called alpha-synuclein, turns out that green tea extract effectively blocks the production of alpha-synuclein. Furthermore, the commercially available antibodies that I'm currently prescribing are about the only other treatment that can remove the alpha-synuclein misfolded proteins, as well as remove all of the other types. So this is why it's so important to find out whether there's elevated misfolded proteins in the brain, as well as to find out which types, because I don't know how to prescribe until I know that. Now, this is a very important slide because it gives us a much clearer understanding of the progression of Alzheimer's disease. And it's very clear from many, many studies that the amyloid that first accumulates for up to 50 years before the tangles form, they are like the match, but the forest fire are the tangles. The progression of Alzheimer's is largely due to the production of the tangles. And the tangle misfolded proteins literally result in neuron death, whereas the amyloid only interferes with the communication between nerve cells. And it's much less harmful than the tangle proteins. What this slide shows you are three basic stages of the spread of the tangles in Alzheimer's disease. Initially, there is normal function. An individual may be aware of some change or decline in their memory. All of us over 45 have probably noticed that, but we can still compensate. We take notes, we use an iPhone, we keep track with an appointment book, and we can function normally, and we don't require others to remind us all the time, unless you've always required others to remind you all the time, which is basically me. I always require people to remind me, but that's always been true. I'm talking about a change, but I can function normally. Now, during that stage, there are either no tangles at all, or there are only tangles in the very first area that they occur in Alzheimer's disease. That's got a name, it's called entorhinal. And you see the entorhinal underneath the stage that says no symptoms in red. And that area of the brain has a very specific function of recording new things that you experience, hear, see, touch, taste, feel. It then allows you to recall that specific detail for up to 2 weeks later. And it takes several minutes to actually do the recording. And if that's the only place there are tangles, you may notice some trouble with details recall, but you'll still be able to recall the gist of an experience, a recent conversation, the gist, because that's not the job of the entorhinal. The entorhinal stores the details, but the details are put together and associated into an experience in the next area where the tangles progress, which is the middle part of this slide. And that is the mild cognitive impairment stage, when the tangles have spread to the second area, which is called the hippocampus. Stands for seahorse in Latin. Now, at that point, compensating by using an iPhone, or if you're an Android user, that's fine, or an appointment book, it doesn't work anymore. You forget to check it. For some reason, you start missing appointments, okay? Forgetting to follow up on details. And now your partner or someone needs to provide reminders, or you get in trouble. This is so-called the mild cognitive impairment stage functionally for Alzheimer's disease. And anatomically and neuropathologically, it involves the tangle spread to the hippocampus. Now, people can still do all their well-learned skills. For example, if you've taken the care of the bills all your life, or paid all the taxes, or cooked all the meals, those are well-learned skills. They don't get impaired in this stage. So this is the earliest clinical stage of Alzheimer's disease. But then if it goes untreated, it will progress to the dementia stage. The dementia is not a diagnosis, it's a severity. It indicates the tangles have spread to the areas of the brain called the cortex, the surface of the brain that controls all the well-learned skills of life. So in knowing these stages, if we can identify people while they only have the tangles in the entorhinal, where they have normal function, at that point, the only thing we're dealing with is a small amount of tangles there and a lot of amyloid. And when we treat that, we have the potential to prevent the progression to the functional impairment of Alzheimer's disease. So I'd like to show you a rather busy slide, but I'll break it down and hopefully it'll be clear. On the bottom of this slide, on the x-axis, you see a measure that I use, which was developed by Barry Reisberg at Einstein in New York. It's called the Functional Assessment Staging Test Procedure, and it's probably the most well-validated measure of your functional abilities that depend upon how well your brain's working. And remember, I was talking about the pathological stage where there's just the tangles in the entorhinal, or no tangles at all, but just amyloid. Well, the first above the portion that says no subjective decline, fast stage 1, those purple and blue areas that I've circled show the accumulation or amount of tangles that are in that entorhinal area. And individuals are functioning normally. The solid white arrow that goes up from birth to 45 years old represents the accumulation of both the amyloid and the tangles until they reach about 45 years old, when that accumulation has reached a level where now there's a definite awareness of a decline in memory, but we can still compensate for it. That's the so-called stage 2, both pathologically as well as with the functional assessment staging test, stage 2. Again, normal function with compensation. Now, the solid pale blue arrow indicates the untreated progression to the mild cognitive impairment stage, but you also see some dotted line arrows. Those are if we recognize the presence of these misfolded proteins and initiate treatments that remove them. When we do that, we can alter the course so that it either never goes into the clinical stage of mild cognitive impairment or takes a very, very long time to get there, so that by the time you're 85 or 100 years old, you might enter into that stage, as opposed to 70 years old if it went untreated. The next stage is in pink. That's the mild cognitive impairment stage. Again, those are a stage where well-learned skills are preserved. Now, point out, I can't cook. I can't even boil water. But that doesn't mean I have mild cognitive impairment because I never could. We're talking about things you used to be able to do and have lost the ability to do. The mild cognitive impairment stage refers to the loss of memory-related abilities, and the dementia stage refers to the loss of well-learned skills. Again, the solid pink line shows the untreated progression, and if we intervene and diagnose and identify the misfolded proteins and begin to treat them and remove them, then we have the potential to prevent the progression to the dementia stage, or delay it enormously so that in your 80s or 90s, you don't get to their dementia stage until, as opposed to reaching there by about 75 years old in the untreated approach. Well, finally, we have the dementia stage. And that typically begins about 75 years old in the untreated person with Alzheimer's pathology in their brain. And again, diagnosing and treating it and lowering the misfolded proteins does in fact delay the progression. But it's much less appreciated because there's already so much impairment. So the big message here is that we can delay and in some cases partially reverse the symptoms and dysfunction of Alzheimer's disease, but the amount of delay or the perceived benefit is going to be less the more impaired we are when we start. So stage 2, functionally normal, or stage 1, we pick it up there. We have the real potential of preventing ever getting symptoms of Alzheimer's disease. Stage 3, mild cognitive impairment. There'll still be some mild cognitive impairment, but we have the potential for never moving into the dementia stage. And unfortunately, in stage dementia, stage 4 to 7, we can delay it, yeah, but it's not perceived as beneficial as these earlier stages. So now I'd like to show you the beginnings of partial reversal and prevention of Alzheimer's disease. Currently, you see these orange arrows, and they point from persons who have spinal fluid levels of misfolded proteins that meet the diagnostic criteria for Alzheimer's disease, who have been treated for up to 6 years. And we have been able to remove enough misfolded protein so that they now no longer meet the criteria for Alzheimer's disease. They may still have elevation of amyloid, or they may have elevation of the tangles, but they don't have both. Or they may no longer have elevation of either. And we have an increasing number of patients who have accomplished this. All of them have been in the functionally normal stage to get this level of reversal. So this is real and prevention is real, but if we're going to accomplish it, we have to change our approach and rethink Alzheimer's disease. So I'd like to point out that the CHIPS trial, which I've talked about in the past, and we will be able to extract a person's blood and take out from that blood antibodies they have against their own misfolded proteins and see if they have an excessive number in their brain. And if so, we can then have them inhale with a special inhaler that gets it into the brain, their own antibodies. And this has the potential to remove 20 to 100 times more misfolded protein than the intranasal antibodies we can currently prescribe, which, as I mentioned, only a small percentage of them are targeting the misfolded proteins in the brain. By using a person's own antibodies, that are purely against the misfolded proteins in their brain, we reach 100% of those antibodies and get a lot more removal, a lot fewer potential side effects. And so this is where we're going. I'm myself am disappointed that we haven't been able to start, but I've learned that there are institutional barriers that one has to jump and hurdle. So we will be presenting to the FDA in the early part of 2022 to get approval to initiate the study. Finally, I'd like to leave you with an overview of what is needed to prevent the symptoms of Alzheimer's, and I'm hoping other degenerative brain diseases as we gain greater experience with them. This is something I call the prevention process, and it's not very complicated. One can use a tool called the Risk Assessment Index to identify risk factors, to monitor them and make sure they are well controlled, to treat them if they are not. That's step one. And step two is to annually check or screen for a memory problem. And if everything's fine, we have you come back in a year and recheck it. And we keep doing that until we find something wrong. If we find something wrong, then we diagnose it. Now, it might not be Alzheimer's. It might be vascular disease, blood pressure, diabetes, hardening of the arteries, heart disease, kidney disease. Virtually every organ is connected in a real way to the brain and affects its function. The brain and the body are a system. They are not separable. And by treating the underlying cause of cognitive impairment, whether it's from an organ or from Alzheimer's or some other misfolded protein disorder, we get the best results. So it doesn't require a huge change. And actually, we're very, very familiar with this process. We do screening for every organ in our body to prevent all sorts of diseases. And we can do that for Alzheimer's disease and other dementing disorders. The most sensitive tool for doing that is literally a 10-minute memory test. Myself and a number of people much smarter than me helped develop it, and we've been using it at the Shankle Clinic and elsewhere. In Japan, they use it as part of their national prevention program. It's a 10-minute test that's 97% accurate at distinguishing normal aging from the earliest clinical stage. And as a result of some brilliant research by Professor Michael Lee and Jason Bach, Professor Lee is Professor of Cognitive Science at UC Irvine. They have developed mathematical methods of taking your memory test performance and predicting which individual will progress to develop Alzheimer's within 3 to 4 years and which individuals will remain normal. And so this is among normal individuals. And I have been told by the president of the company that has done this, that they will be able to implement this algorithm on the MCI screen in early 2022. So that provides a critical step for detecting brain pathology, Alzheimer's, while people are completely functionally normal. And then it becomes very easy to diagnose if there's a misfolded protein disorder or some other cause that needs to be treated. So the era of screening for brain disease has arrived. That's all I had to say. I hope you have learned something. I've learned a lot over the past 33 years, and I'm very grateful to all the people who work with me. I wanted to also introduce, I have a new nurse practitioner. Her name is Sarah Ray. And for those of you who come to the Shankle Clinic, you will love her. She is really, really smart and dedicated. I think with that, I'll stop and turn it over to Connor.
Great. Thank you so much. Fantastic presentation, as usual. Love your graphics. So one question that we had was on the CHIPS trial. You mentioned that the next step seems to be moving towards that FDA approval in 2022. Is that, do you also hope to kick off the trial in 2022, or what's the latest there?
Yeah, the biggest hurdle has been to pull together the data from the 110 patients that now have been treated, and to be able to put it in a presentable form for the FDA to evaluate and hopefully approve the use of the trial. I don't expect that they will reject it, but we have to be absolutely certain that we can provide them the best possible evidence of the efficacy.
Great. And there was a question about participation in that trial. So is the best, if people are interested in participating or have family members that are, is the best way to go about that is to reach out to you or someone else at the Shankle Clinic?
So I worked very hard to design a trial that was not exclusive but inclusive, so that it should allow anyone who wishes to participate to be able to participate in the trial. That's very different from the standard FDA trials, where they try to exclude all sorts of things so that there's no variability across individuals. So we've thought about ways that you could account for that variability and still detect treatment effects. There's another thing that's, I think, will be very, very useful for adult children and other individuals who have normal function, but may be concerned that they have misfolded proteins or they're at higher risk, such as having a family member or having had a head injury or high cholesterol, many, many things. And in that case, we are putting together a prevention program through the Shankle Clinic that involves risk factor identification and management, plus periodic annual or semi-annual memory testing. If a person is identified to potentially have an underlying condition like Alzheimer's, and we do validate that it's due to a misfolded protein, there is a clinical trial now called the AHEAD 345 trial, and they are enrolling individuals who are functioning normally and only have elevated amyloid in their brain. And that would be the majority of individuals who are functioning normally will have only amyloid elevated in their brain, or may have just some tangles in their entorhinal. Those individuals are very likely to be eligible to get a treatment that removes the amyloid. It is an FDA double-blind trial, so there's always the chance of a placebo, but this is really targeting preventing the development of the symptoms. So there'll be potentially two options, one now, the AHEAD trial, and that's why we're working hard to start the prevention program in 2022. And then further down the line, when we get approval for the CHIPS trial.
Great. And just in terms of the process, will you be, or will the Shankle Clinic being sending out an update on those trials and with information on how to express interest, or should patients be reaching out proactively?
I think that I'm always going to get in trouble with my office team because they are the ones who actually have to plan the logistics and everything. So I should be a little careful about what I'm saying, but we are in the planning process for the prevention program, and we do expect to start it next year, or that's a few months away. So I'm excited about that. I will also include in our newsletter update about the AHEAD trial, the prevention program, and we're working extremely hard to put that together as quickly as possible.
Okay, great. Another question we had, have you performed any testing from the Navex company and their 2-73 blarcamazine data?
Say it again.
Blarcamazine, I think, is the drug 273. If you've heard of that.
I haven't heard about that one. There is a very interesting trial that we will be starting. It's for mild to moderate dementia due to Alzheimer's disease. And it's a treatment called simufilum or simifilum. That particular treatment is very novel, and it has the ability to remove both plaques and tangles, misfolded proteins. It's actually had very positive results in terms of being able to remove 9 of the 11 biomarkers that they use to measure the disease process in the phase 3 clinical trials, and they're starting a second phase 3 trial now. So for people with mild to moderate dementia due to Alzheimer's, that's a very exciting opportunity.
Yeah, I just did a quick Google search, and it looks like blarcamazine by Navex, if I'm pronouncing that correctly, is in phase 2B, phase 3. So add that one to your list to check out.
You might want to send me the name on that. I'll review.
Yeah. Okay. Fair. I will do that. Okay. Next question. How, I know that you could probably do an entire lecture on this one, and we've done longer segments, but the question was how best to determine risk factors. What are they? Hereditary, other, in addition to spinal fluid and brain MRI, and tools obviously like the MCI screen. But if you could just talk a little bit more about that as well.
Yeah, there's some really good work by Karen Anstey from Australia National University, and she helped develop the risk assessment index for dementia. It's called the RAID index, and as part of the prevention program, we will implement that index to establish a baseline risk score that's been validated against autopsy data in Alzheimer's disease, and then to address the risk factors and see if they can be improved so that we can use that risk score, the RAID index score, to measure whether you've actually been able to reduce your risk by risk factor modification. So we'll have a way of quantifying how much your risk has changed as a result of your behavior. I think that's the best tool out there.
Great. And some of these tools that you're talking about, in addition to the MCI screen as well, we had a question, are they available now, and are they available outside of Southern California? And so for those those participants listening that are not in Southern California, how might they go about getting some of these screens done?
The risk assessment index is in most circumstances, it's been used as a research tool, but we're going to bring it into the clinical setting. The MCI screen has been used since 2002, and it is internationally used, Japan, China, elsewhere. It is available online through MBIC Corporation, and it's administered by an individual using the online screening instructions. It's available for any clinician's office or other site where they do memory assessments. It's used by the Orange County Vital Brain Aging Program, which can be accessed and tested periodically. They do it as part of the Vital Brain Aging Program's mission of trying to prevent dementia. It's available through the Shankle Clinic, and we can also do it remotely, so that it can be administered by phone, by telemedicine, or in person. So it doesn't particularly matter where you live, as long as you can access some place that administers the screen. Like I said, it's a bit sporadic because not every physician uses it. So that's one barrier, would be to know who's using it and who's not, but it's fully accessible to any clinician's office anywhere in the world.
Great. Thank you. So you had mentioned the 110 patients or so that you've treated with the antibody inhaler. We had someone questioning why that number is not larger than 110. Why hasn't this been more popular, perhaps?
It's a good question. I think it's 110 more people than anywhere else in the world. So that's one way of thinking about it. It certainly involves a commitment, because if we're going to do this, we need to do it right. And that means we need to measure. And in order to measure, what I do is I get spinal fluid and measure the levels of the misfolded proteins prior to starting treatment. I get a quantitative MRI to measure the brain volumes prior to starting treatment. And we also do the cognitive and functional assessment prior to starting treatment. So we have baselines as a way to measure the effect of the treatment over time. Periodically, we repeat those measures. We repeat the cognitive and functional measures every 4 to 6 months or 3 to 6 months. And we repeat the MRI and spinal fluid measures about every 2 years. So it does require a commitment to actually doing that and learning how to use the inhaler. It's not hard, but you still have to learn it. So it's not just sign me up. There is a bit of a commitment. I have been, unfortunately, I'm still the only person in the world who's used it, and I'm not proud of that. It would be much easier to say that it's being widely used by lots and lots of people, and I'm very careful about measuring. So I had to convince myself over a period of 15 years using the intravenous approach that it really was working. And that's why I do such objective measurements. I think you're going to see over the next few years an explosion of use of intranasal therapy for all sorts of brain disorders. But at present, most of the pharmaceutical companies are still using intravenous treatments, which are much more expensive and much more invasive. I can't tell you exactly why they have not switched over to intranasal use, other than they are the Titanic, and it takes a lot to turn the Titanic.
Great. Thank you for that. Well, with that, that seems to be the last question, and we're right at the 1 hour mark. So I think we'll wrap there. Dr. Shankle, thank you so much for your presentation and taking the time to answer these questions. It was fantastic, as always. And I guess anything in closing that you'd like to say?
Yes. Take seriously the idea of screening the brain. It's real, it works. I've got an accumulating number of people who would have been demented by now, and 10 years later, they're still doing well. I'd also like to say special thank you to you, Connor. And I'd like to just let everyone know that Connor is now the proud father of baby Logan.
Yes. And you didn't hear in the background tonight, which is a success. The smoke alarm went off, but the baby didn't cry. So little victories. Thank you.
All right.
Okay. Thank you, everyone. Have a great night, and look out for this on the Shankle Clinic website, the recording, and also on the Shankle Clinic YouTube channel in the next few weeks. Have a great night.
Bye-bye.